not necessarily the respiratory tract there, but are there any viral particles that can be transmitted through the blood if they're being aerosolized? Some of the other things that have been looked at were, so for protecting anesthesiologists during their intubation procedures, they get N95 masks, but surgeons aren't getting them for those procedures because they're allowing the air in the operating room to cycle out a few times before the rest of the operative team comes in to finish the procedure. Some of the things I looked at were, are they giving enough time in order to ensure that this infectious risk has dropped down and you're doing what you can to protect the surgical team before the procedure starts? That raises a couple questions in terms of balancing the safety of your patient and the surgical team, because if you're waiting 20 minutes, sure, you might have a clearance of viral particles in the air to a 99% efficiency that'll allow the surgical team to operate with minimal risk to themselves. But that's also a not insignificant extra 20 minutes of anesthesia time for a patient who has been inducted, is unconscious, and is now being, for all intents and purposes, placed on life support for that time in order to continue the case. So it's a lot of the questions the surgical team has asked about have been a balancing act of making sure that the patient is protected while protecting non-infected individuals, both healthcare workers and patients alike.
Austin, thank you. Like with all of your colleagues, I mean, excellent research, and we deeply appreciate the work that you're doing to try to both make healthcare workers and patients safer. A quick follow-up, just so I'm clear. In the last case that you described, where where the recommendation is to let the room air out for 20 minutes or so, would the issue be resolved? Suppose we had a plethora of N95 masks. If surgeons had N95 masks, could that reduce the time that the room would have to air out?
Theoretically, yeah. If everybody involved in the procedure is wearing an N95 mask, which wouldn't be the most ridiculous stretch because within the OR, everybody is wearing a surgical mask to begin with anyway. If they just upped that to an N95, theoretically, you could be doing the procedure faster, but you might need some time in order to to allow the settling of particles that are produced during the intubation, but you would probably need less than 20 minutes.
Excellent. Thank you very much. We appreciate your research. We're going to move to our next panelist now, Kevin Brandecker. Kevin Brandecker is also a medical student at Hackensack Meridian School of Medicine at Seton Hall. So we've talked a bunch already about PPE and relative protections for healthcare workers, both sort of generally in specific instances with respect to different kinds of health sustaining or restoring practices. Kevin's been doing some work relative to possible vaccines, in particular remdesivir, if I understand that correctly. So Kevin, do I have you on the line?
Yes, Brian, I'm on the line.
Excellent, great to have you. Could you please share some of your research with us about some of the drugs that we all read in the paper but don't know enough about?
Yeah, so I work on the hospitalist team, and one of the questions that we got asked a lot, especially, was what possible treatment options are there out there? So one that I specifically focused on was remdesivir, which is getting a lot of attention in the news now. So it's a nucleotide analog prodrug, which means that it's pretty much taken into the body and then incorporated into the viral RNA. And what it actually causes is the viral replication process to kind of stall and stop, limiting how much virus you can produce. So kind of one of the difficulties they've had, especially with coronaviruses in the past, like SARS or MERS, is that they can have a proofreading function, which will actually be able to help them kind of remove and prevent the addition of these drugs. So they're able to get around a lot of treatments. So early in the outbreak, as they were screening and looking for different options for medication, remdesivir came up. So it was initially developed to be tried in Ebola. So it was used during the 2016-2017 outbreak in Ebola, but wasn't as effective as other medications, so it was stopped, but it allowed for kind of the safety profile of the drug to be built. So once the outbreak started, they were able to do trials in cells and were able to see that it was able to inhibit the growth of the virus. And then kind of using that in the prior safety data, they were able to start doing some compassionate care trials, which meant that physicians or other providers could contact the drug company and ask if they could use it to treat their patients. And as that was kind of building steam and starting, they also started a number of randomized clinical control trials, which are currently going on in a large number of centers. And these are going to kind of ultimately provide the data. Does remdesivir kind of make a difference? So while it's gaining a lot of attention in the news, a lot of publicity, especially with some data that had just come out of University of Chicago that got leaked, there's really still kind of, we have to wait and see for this data from the randomized control trials to see how effective it will ultimately be as a treatment option.
Excellent. Thank you for the update and for the clarity and the way, sort of the level you pitched the science at, because I know for non-clinicians like myself, and I'm sure a bunch on the call, we've read a lot about it. Remdesivir was highlighted in the New York Times Magazine section a couple weeks ago. But sort of the way you pitched it was really helpful. And I also very much appreciated, not your hesitancy, but your sort of cautious optimism and the importance of clinical trials. Dr. Fauci agrees with you. I think he just came out with some comments that sort of mirrored your comments well. So thank you for doing this work and for your willingness to share it with us. We're going to move to our next panelist, Candace Polito, who's also a second-year medical student at Hackensack Meridian School of Medicine at Seton Hall University. So we've talked about PPE, we've talked about some of the drug, or one of the drugs that's being tested as a possible response to COVID. There's a lot of concerns, and we're starting to see some very wonderful stories about folks with COVID coming out of the hospital and coming back home. And of course, the questions that pop up right away are about viral shedding and all the stuff that we hear about antibody research, what it might mean, what it might not mean. We see national political leaders and statewide leaders disagreeing on some of this information and what that means. So thankfully, Candace is with us and she's been doing some work on this. So Candace, do I have you on the line?
Yep, I'm here. So I've been working on the infection control and prevention team with Katie. And as more people recover, there's even more questions emerging about assessing their risk to other people. So in terms of viral shedding, it seems that people begin shedding the virus 1 to 2 days before symptoms start, with peak viral load being 3 to 5 days after the onset of symptoms, but then it slowly starts to decline after 7 days. The current studies aren't great and the results vary, but it seems that shedding can be under 2 weeks in more mild cases, but that the average can be around 20 days in more severe disease. The results can also change depending on the sample taken. For instance, fecal samples seem to be positive longer than respiratory samples, regardless of disease severity. The main problem is that no studies have looked at the infectivity of this period, so we don't know if the shedding in the recovery period is really an issue. At this time, there's still ethical concerns about putting other people at risk, and we should be adhering to the CDC guidelines for reducing isolation precautions and criteria for healthcare workers to return to work after being sick. The non-test-based strategy for this is being used now in most places, especially around here because of the backup and lack of reliability of current testing. And these criteria include being fever-free for more than 3 days without using any fever-reducing medications, improvement of respiratory symptoms, and 7 days since the onset of symptoms. For people being discharged home, there are a lot of places are also recommending an additional 7 days of isolation just to be safe. The next hot topic is antibody testing. So most studies are showing that people develop an IgG antibody response by 14 days, but the length of this protection is really unclear at this point. In the US, there's over 70 antibody tests on the market, but only 2 of them are actually approved under the Emergency Use Act by the FDA. And these are the CELEX lateral flow assay and the ELISA IgG from Mount Sinai. Looking at the limitation of these antibody tests, cross-reactivity with other antibodies similar to similar viruses actually does not seem to be an issue, which is a good thing. But the main problems are that there's no gold standard test for comparison and that all of these studies are based on small sample sizes. There's a lot of discussion right now about using these tests to help reopen society, but we really have to be careful until they're reliable enough and figuring out when that will be and what those thresholds will be. Overall, when the antibody testing improves, it can be used for contact tracing of asymptomatic individuals, understanding the efficacy of the vaccine that's being developed, and also assessing immunity of people as social distancing restrictions begin to decrease.
Excellent. Thank you, Candace, for your work on both of those important topics. And I take it, like Kevin, we should approach these with cautious optimism. So thank you very much. We're going to turn to our next panelist, Kristen Rinaldi. So we've heard some of the challenges. We've talked through some of the research that's been going on. For folks who aren't engaged directly in research but still want to aid, there's some really creative responses. So Kristen, do I have you on the line?
Yes, hello.
Wonderful. So Kristen Rinaldi is a physician assistant student at Seton Hall in the School of Health and Medical Sciences, and she is the president of the PA Student Society at Seton Hall. Kristen started a fundraiser, which I'm going to ask her to share with all of you. So Kristen, could you tell us about the work you're doing?
Sure. So our student-run organization has organized a program-wide COVID relief baskets fundraiser. About a week and a half ago, I was catching up with some of our faculty who are currently working in the ER and on the COVID units, as well as in urgent cares. They were all expressing how they're very proud to be on the front lines of the pandemic as physician assistants. Specifically, Dr. Yerger Marshall and Professor Morello Bruza both mentioned that they were extremely thankful to have been supplied the proper PPE to continue working. However, they both mentioned how painful their ears had become over the last few weeks due to wearing N95 masks 12+ hours a day. It became apparent that small things can really become a larger issue day to day for the essential healthcare workers. We have seen many student organizations across the country find ways to be flexible during this unprecedented time and volunteer while continuing our educations online. We cannot take credit for being the pioneers of COVID relief donations and efforts, but we are very proud to be doing our part for our future colleagues. One of the most rewarding parts of this project is seeing our program come together. We have had student, faculty, and even alumni involvement in the project. Collectively, in 10 days, we have raised over $13,000 for COVID relief baskets. These baskets each contain a button headband or tension release clip to assist in ear pain, a $25 gift card for either gas or groceries, a pack of lifesavers, as everyone is lifesavers right now, and a thank you note written by our PA students. With our generous donations, we are on track to be able to donate over 300 baskets to our local hospitals. These baskets have been and will be going to St. Mary's General Hospital and Hackensack University Medical Center. Our intentions for these COVID relief baskets are for distribution to a variety of personnel, including, of course, our healthcare practitioners, but we also are looking to include custodial and maintenance staff workers, as well as our colleagues on the security team. We are very thankful to have such a supportive community to come together during this time. We feel that the donations are one of the safest ways to get involved during the pandemic, which has become an ethical dilemma, how we can get involved. While we may not be able to assist in the clinical setting as students, we have found a way to assist our future colleagues without leaving our homes. There's a need for relief, and we were able to find a way to fill some of this void.
Kristen, thank you for sharing. It's a wonderful project, and the way you've paid attention to the nuance and things that I'm sure many healthcare practitioners realize, but a non-clinician like myself wouldn't pick up, not thinking about the ear pain and the other things from being in the N95 masks or the PPE for that time. So we're really appreciative, and fitting with the whole theme of this session, that you've found a way with others to do this safely. So thank you. And for our audience, we're gonna have some information about Kristen, about her program and the physician assistant program. For anyone who's interested in helping out, we'll have that at the end. So thank you again, Kristen. We're now gonna turn to Kara Underwood. Kara, are you on the line?
Yeah, I'm here. Hello.
Hey, welcome. So Kara Underwood is a nursing student, class of 2020 in the College of Nursing at Seton Hall. And given all of the ways that students have been involved, Kara's stepped it up another level and has actually become a nursing assistant and is working in direct care at St. Peter's University Hospital. So Kara, thank you for your work. And if you could share some of your experiences with us and our audience briefly, we'd greatly appreciate it.
Yeah, of course. Thank you for having me. And thank you to the other panelists for shedding some light on the PPE issues that have been going on. I definitely see that in the hospital, but I just wanted to take a minute to talk about more of the mental and psychological ethical issues that have arisen, especially on my unit. So I started working on a cardiac CPCU, cardiac progressive care unit, in December. Honestly, I started as a resume booster before graduating. But by mid-February, we started to see a sudden shift with the pandemic. My floor was the second after the ICU to be converted to a COVID unit. And since then, we've only seen an escalation in the number of positive patients, as well as the deaths on my unit. So I have never experienced a death prior to this as a nursing student. Working in the healthcare field, I've never seen a death. And to be honest, it doesn't get easier. So one of the huge burdens that we bear working during this time is we are the only people that our patients get to interact with face to face. So with the current visitor restrictions in place, obviously to keep people safe, we as nurses and healthcare professionals become the only form of family the patient really has. So when they're dying, we are the ones holding their hands and we are the last ones to see them. And as terrible as it sounds, we are also the ones preparing the bodies to be seen over FaceTime with the families when they pass. So it weighs very, very heavy on me personally as a caregiver, as well as the rest of my team, the nurses, the doctors. So I sometimes feel that the overwhelming sense of care and empathy that I have for patients that makes me a good nurse is also, you know, the downfall in this scenario, because it's very hard to keep spirits up on our unit when we carry every death with us, as much as they tell us to leave work at work. But to know that we are the comfort for these people is obviously also extremely rewarding. You know, we do get to see these patients turn the corner and recover after days of struggling to get their oxygen saturation up. We get to receive calls from family members thanking us for keeping their loved ones alive. We get to receive an outpouring from the community and family members sending food to our unit, which is amazing. You know, with the good and the bad surrounding the pandemic, it's kind of exhausting with the extreme emotions that you feel every day during the shifts, good and bad. It's so intense that it's definitely draining. You know, the shifts not only have become longer hour-wise because of the understaffing, they've become longer because everything is so extreme during this time. So at the end of the day, this isn't what I originally signed up for. You know, I did this because, you know, I wanted to get a taste of what I was getting in my career, but you know, somehow through all of this, it has only reinforced that this is what I'm called to do, to give myself to help others. I just didn't know exactly how hard that would be.
Kara, thank you for sharing the experience with us. And I know I echo all the members of the audience and thanking you for your work and noting that you're a wonderful representative of the College of Nursing at Seton Hall. Hopefully, maybe we'll see if some of Kristen's baskets can get over to your unit, so and provide some relief. So thank you very much. We're going to turn now, and again, Kara, stay on. We'll see what happens in the question and answer session. We're going to turn now to our final panelist. So we're going to turn to our final panelist for folks, especially who know people like Kara who are doing this good work and thinking, what can we do? What can we do safely if we don't have the opportunity to assist as a healthcare practitioner? Clara Chen has come up with a really interesting idea. She is a second-year med student at Hackensack Meridian School of Medicine at Seton Hall. Clara, do I have you on the line?
Yes, I'm right here.
Wonderful. So Clara, like Kristen, has had an innovative approach to how folks can help. So Clara, can you share with us what you're doing? And that would be great.
Sure. And first, thank you so much to Kara and all the panelists for all your amazing stories and research and work. It's actually really inspiring. And so I guess my approach to helping with the COVID effort was to write a letter to the White House explaining my concerns about the federal government's response to the COVID pandemic. And so just to give some backstory, as you all know, the lack of PPE and ventilators has been and continues to be a really concerning issue across the country. And a month ago, I didn't really know how I could help with the problem. But two things happened. First of all, Dr. Syracuse, one of our medical school professors, she sent us an email urging us medical students to write letters to the White House. And she also outlined instructions on how we can do that. Secondly, I heard about a law that the federal government could utilize to coordinate a nationwide response to increase the supply and to direct distribution of ventilators and PPE to hospitals that needed it most. And this law, which has been used hundreds of thousands of times in the last year alone, it was inexplicably not being invoked by the president. And that type of inaction, not using a tool that could vastly help the COVID-19 efforts and protect our healthcare professionals, that fired me up. So for the first time in my life, I found myself compelled to write a letter to the White House to explain my concerns. Later, I also sent a shortened version of the letter to my peers and encouraged them to send out their own messages to add their voices to the growing pressure on the federal government to take more effective action in helping with the COVID-19 crisis. And so I'd never done anything like this before, but I decided to write the letter that day because I realized that there's no better time than during this COVID-19 crisis for future health professionals to engage in advocacy. And I think as students, I feel like we often tend to marginalize our own thoughts and think that we're too early in our career to make a difference. At least I know I sometimes think so. But as Dr. Pilkington mentioned at the very beginning, as healthcare professionals in training, I also realized that our medical opinions already hold significant weight in society, since we already have a unique insight and thus also basically responsibility within the healthcare system. So that's why I felt it was so important to write the letter, and I'm glad I did so, because earlier on in the quarantine, I found myself, it was like kind of easy to wallow, feel confused, a little overwhelmed. But writing this letter really made me do a lot of research, which kept me informed, and I feel like it empowered me to look into other offline opportunities as well to help with the COVID-19 crisis. So I think my takeaway from this experience and going forward is that there's like many ways to take action, even in quarantine, as obviously with like my peers' really great stories and approaches. But regardless of what route you take, this COVID-19 pandemic is exactly the type of situation where I feel like we have an obligation to get involved, lead discussions, and become part of the movement to find a solution and improve the healthcare system for our future patients. And so that was my experience. And since I'm the last panelist, I just want to reiterate and thank Dr. Pilkington so much for this opportunity to briefly speak about it. I also want to mention that there's several great websites if you have or know of any PPE to donate. There's one called getusppe.org. There's another one called donateppe.org. And I'm not sure if Dr. Pilkington is going to talk about it later, but I guess I just want to say that later I think I'm helping to organize, as you mentioned, a letter writing campaign. So we're going to have a separate Zoom session where for the first part of it, participants can discuss the federal government's COVID-19 response, whether it's good or there's things that might be of concern. It could be really any topic. It doesn't have to be PPE or anything, but I think we could discuss, share resources, and talk about our thoughts in a safe space. And in the second part of that meeting, I think we could start writing drafts of letters to the White House. And because I think writing together, even over just Zoom, would be helpful. And I want to emphasize that you don't have to have done lots of research on specific subjects, but we would love for anybody to join and just be part of the discussion, maybe learn a little bit, and help get your voice to the White House. So I hopefully look forward to an email with more details, and that should hopefully happen soon within the next few weeks.
Clara, thank you very much, both for your initiative and your work with Dr. Siracusa to write these letters and your careful attention to the safety of healthcare practitioners. I have a couple comments and questions as follow-up for our panelists, but I want to open it up to the audience. So please, if anyone has any questions, send them through the chat function, or if you have questions, please do feel free to tweet those questions at SHU Bioethics. We'll check the Twitter, we'll check the chat. I know a few people have sent questions in via other means as well. So one of the things I wanted to highlight was, which I think came out very nicely in terms of the research that was done by a number of our medical students, the experiences that Kristen and Clara have had, and what Kara has done, is we see a mutuality between protecting healthcare workers and also protecting patients. So I think this was especially the case in the research that Austin has done, where he shared with us that, which he of course spoke much more eloquently about, the airing out for 20 minutes of surgical rooms so that surgeons could do their work without the N95 masks. Now we tie this nicely to the work that Clara is doing in trying to get more PPE, if there are enough N95 masks, if everyone has them. all those who need them, then we don't have to worry as much about that 20 extra minutes that the patient is in anesthesia. So though sometimes these conversations are framed as protecting healthcare workers as opposed to doing the best for patients, there are also situations where we're really looking to other parts of society. Clara mentioned one of the military production acts that was not invoked, but we're really looking to other areas to do work which benefits both healthcare practitioners and also benefits patients and the rest of us. So I'm just checking our Twitter for questions. So the other thing I wanted to mention as I wait for more questions to come in, well, to highlight, is you have up on the screen now an advertisement for Kristen's program. We will put all of this in our discussion board. So you can join the Microsoft team, join the discussion board. We put articles and other things referenced by our panelists there, and you'll also have the opportunity to donate and connect with Kristen and her work as well. Finally, Clara mentioned a second session that we're going to be doing. So Clara, along with Kelly Freeman, who runs Student Affairs at IHS, she's the Director of Student Affairs, and myself, we're going to have a special ethics session to sort of build a community around letter writers. Clara is going to lead us in this, as she mentioned, and we will share that information through all of our channels and see if anyone wants to join us on the Zoom call as we write letters, both nationally and also more locally, to try to get more PPE for the folks who need it and hopefully end up with better patient outcomes. Please do join us. We'll be sure to share that information. So one question that I had, and there are a few questions that have come in sort of generally in this area. I think it's best to direct this to Candace Polito. So I'm scooting back to her slide. Candace, do I still have you on the line?
Yep, I'm still here.
Wonderful, thank you. So there have been some questions that have come in asking you to say a little bit more about the antibody testing, and they're from non-clinicians. So if there's anything that you could add or sort of re-explain in a way that those of us who lack some of the medical terminology could understand, what are your recommendations, albeit provisionally, about antibodies and what this means?
So a little more specifically on the test, one of the tests, the lateral flow assay, is basically like a pregnancy test for antibody response. So it's just positive or negative. And then the ELISA IgG is a little bit more quantitative. But overall, the big issue is because we don't have like the gold standard to comparison. So there's no antibody test for COVID-19 right now. We don't know if these tests are actually effective or not. So that's why it's hard to employ them. They are based on a positive agreement percentage, which is basically taking a sample of people that have tested positive, which again, there's limitations with the current testing. So it's hard to, they're assuming these people are positive and they're going based off symptoms and they're pretty sure about that, but they're just comparing it to that sample of people and not actually other antibody tests. So that's why we have to be careful on basically relying all relaxation of social distancing measures on these tests, because there's definitely a lot of weight being put on them right now when they're not fully like ready or developed to be used in those capacities. Do you want to speak in any more detail or?
That's excellent. I think that gets at what was behind some of the questions that came in, because they were asked in conjunction with the possible relaxing of social distancing measures. We've seen the suggestions in different states. At different times, we've seen suggestions nationally. And as you know, much of this, when these claims are made, there's a reference to these tests. So that's very helpful. Thank you. The next question that I have, I think, is probably best directed toward any of those researchers we have on the line, maybe Katie, Daniel, Eric, maybe Austin. And it's about, it's a little bit off topic. So any of you feel free to jump in and I'll switch to your slide. Or it's a little bit off topic from what you've been working on, but there have been some stories about inappropriate usage of PPE. And by that, I mean something like folks who don't really need it, who could be social distancing, but hoarding or wearing or continuing to use N95 masks. Do any of you, since you've done some work on PPE, have any ethical reflections on those who it seems like don't need N95 masks and who are using it? Or is there any helpful information you might be able to share from your research on PPE about why folks might not need to, and then hopefully leave the resources for those in the healthcare field? So if Katie, Daniel, or Eric has a comment on that, that would be most welcome.
This is Katie. I don't know if there's a right answer to this question, but I do think it's easy to go into a food market and see somebody wearing an N95 mask and think, oh, you know, you shouldn't use that. You should use that. Like, you should be giving those to healthcare workers. However, we don't know what kind of health conditions they have. We don't know what kind of health conditions their family members have. So I think that definitely some people are using these N95 masks when they don't need to be, but we also shouldn't just judge, like, we don't know what their background is. So we shouldn't be judging and maybe making mean faces at people or whatnot, because we just don't know what their situation is. A lot of the recommendations have changed regarding PPE. In the beginning, it was more recommended to really not everybody needs to wear them. And now we've transitioned to the point where you can't enter stores without a mask on. And this is really just to protect and prevent the spread of the disease, to prevent respiratory droplets from landing on surfaces. And I think that's a positive thing. And I think we should be wearing masks when we're going into stores. However, if you are exercising, running outside, away from people, you probably don't need to be wearing a mask.
Excellent, thank you. And thanks for putting our attention also to the big ethical question about interactions between persons and some of the unfortunate stories that we've heard. And we're actually going to take up some of these issues in future COVID ethics sessions discussions, but about making judgments about people without fully knowing what's going on. Katie, since I have you here and I have your slide up, we do have one question that's come in through the chat. And the questioner asks whether there's a standard type of goggle. So I think you're probably the best person for this. If there's a standard type of goggle that caretakers should be using when interacting with COVID patients. And the questioner also asks about publicity. I think maybe she hasn't seen a lot about this, but do you have any specific goggle recommendations for caretakers?
I do. Give me 1 second. I'm pulling up my research. Hold on, it's loading. So the CDC recommends appropriately fitted, indirectly vented goggles with a manufacturer's anti-fog coating. Those are the most reliable eye protection from splashes, sprays, and respiratory droplets. It essentially means any goggle that fits your face well. You don't want any leaks in the seal. And you also don't want them to fog up, because the more that you touch the goggles, the more chance there is that you're contaminating yourself.
Gotcha. Excellent. Thank you. And the question also asked about publicity, but I haven't quite followed what that means. So if the questioner wants to add anything, we can pester Katie. So Katie, thank you very much. I wanted to turn back to Clara and also to Kristen, if either of them had any further comments about the sort of fundraising and the advocacy and the awareness that they're working on, as we see if anybody else has any pressing research questions. So Clara or Kristen, any comments or anything that you can share with us about advocacy, your understandings of advocacy, or anything that brought forward your projects?
Hi, this is Kristen. So I've found particularly that people want to get involved. People who are staying home, they want to do their part, especially as students. A lot of us were very frustrated at first when we were pulled from clinical rotations. Obviously, we quickly realized that there was a much larger issue at hand than missing a few weeks of clinical rotation. But we've realized everyone wants to help, and we just have to find a way and a safe way for people to go and help. So I think the advocacy and bringing the community together has been very easy because people want to come and join the efforts. And specifically just because I'm representing our program right now, we're all very excited and very proud to be part of something like this.
Excellent. Thank you. Kristen, yeah, Clara, go ahead.
No, I was just going to say I second what Kristen was saying. And also I think another thing is also just that I think taking action is like really important. I think when I was like writing my letters, I had a lot of like ethical doubts about like if what I was doing is going to have the intention I have putting in these letters, especially writing to something like the White House. I don't know how it's going to be taken, or you also sometimes feel like you're voiceless, but I think it's important to make sure that you do at least put your voice out there and take things one step at a time, and that you're not just like sitting with your own thoughts, but try to do something with it. I think I fall into that tendency. So getting involved with this letter writing has really made me a little bit more proactive in things. And I think sometimes I think to myself, oh, is there a perfect solution? And I try to think about all the ethical like complications. So I think you really just got to step out there, do your research, be well educated on it, but also just have those discussions with people. There's no perfect solution, but I think just doing one thing at a time is really helpful.
Excellent. Thank you, Clara. I appreciate that. We have a few more minutes left, and we're going to scoot back again on the goggles. So, Katie, and thanks to the questioner for clarifying. Katie, I'm not sure if this is something you can speak to or not, but part of the question was about why we hear so much about N95 masks and about face shields and different sorts of things, but we don't hear a lot about goggles, especially given the compelling narrative that you offered for us. So, any suggestions as to why these other PPE materials have been so talked about, but goggles haven't been talked about?
That's a really good question. I think part of it has to do with just the availability of resources. Face shields are, I would imagine, cheaper, and they're just more widely available. And goggles aren't. There's a more limited supply. Additionally, it comes back to who needs what and when. Like, we don't need to be walking around stores with goggles on. If you like, not everybody in the hospital needs to be wearing goggles at all points. It's mostly if you are at high risk for getting droplets in your mucous membrane, so like your mouth, your nose, your eyes. And in the example I gave, the nurse was helping the patient with his high flow nasal cannula, and when she adjusted it, some droplets sprayed. So in a situation like that, goggles would be like very necessary because there is a high risk of exposure. But for healthcare workers just walking around the hospital and whatnot, that risk isn't there, so they don't need to be wearing goggles at all times.
Thank you. That's helpful. We have one more minute left, so I just want to draw everyone's attention again to Kristen's PPE basket fundraiser. This information is also on our discussion board in the Teams chat. So if you'd like to follow up, if you'd like to stay connected, you can always email us at ethics@shu.edu. Do request to join the Microsoft team. If you're familiar with Microsoft Teams, we have one for this. That's where you can get a lot of information that we're putting out, a number of the articles. We also have information from the medical students who have done research. That's there. And we will put there the information on Clara's campaign, her letter writing campaign. Generally, if you're interested in all of the wonderful student events at IHS at Seton Hall, we have the text there, IHS events. You can text that to 55000. Please do follow SHU Bioethics on Twitter and on Instagram, and follow Hall students. We'll continue this weekly conversation going, And to all of our panelists, thank you very much for all the work that you're doing. Kara, thank you for your frontline work. Clara and Kristen, thank you for your fundraising efforts. And for all of the med school medical students doing research, thank you very much. Everyone on the line has been muted, but I know that they're clapping right now. So everyone, thank you for joining us. We'll leave the chat open a bit in case there are any follow-up questions, but please do join the Microsoft team, ask questions there, follow us, and feel free to tweet or Instagram or everything else. Any questions to SHU Bioethics @Hall Students and text IHS events to 55000. So thank you all for joining us, and be safe and well.